Hello, my name is Michael Curry. I'm the Section Chief of Hepatology at Beth Israel Deaconess Medical Center, and I'm tasked with delivering a talk on drug-induced liver injury. These are my disclosures, but nothing that I will talk about today has a conflict of interest. So the incidence of drug-induced liver injury in the general population is not very well known. There are a number of population studies that have been published over the past 20 years from various countries like France, Iceland, Korea, as well as the United States, that provide some estimate as to how many cases of drug-induced liver injury are seen per year. For instance, in France, they see about 14 cases per 100,000 inhabitants, similar to what is seen in Iceland. In Korea, they defined it as 12 cases of hospitalization per 100,000 inhabitants, indicating that there may be more drug-induced liver injuries that did not rise to the level of hospitalization. And here in the US, which is relevant for this discussion today, they talk about the fact that there are approximately 2.7 cases per 100,000 adults attending a gastroenterology practice, most likely for evaluation of abnormal liver chemistries deemed to be thought to be due to drug-induced liver injury. Now, drug-induced liver injury can mimic almost all other liver disorders. It has a wide range of presentations, and it's a difficult thing to diagnose because there's really absence of any objective diagnostic criteria, and we have no biomarkers that specifically determine that something is a drug-induced liver injury. We must always be suspicious of drug-induced liver injury, particularly in liver injury with unexplained causes. And this liver injury could be acute liver injury, or as we will see from this discussion, chronic liver injury as well. Now, unfortunately, the only markers that we have to denote drug injury is the classic ALT, AST, alkaline phosphatase, and bilirubin levels. These remain the mainstay of detecting and classifying liver damage in patients with suspected drug-induced liver injury. In general, drug-induced liver injury should be classified as either hepatocellular or cholestatic or mixed, depending on the OR ratio, which we've discussed in previous versions of this talk. However, I would recommend that if you wish to determine what the OR ratio is, you go to Google and download a calculator. ALT, alkaline phosphatase, and bilirubin are the standard analytes that are used to define a liver injury or liver dysfunction in the setting of a drug-induced liver injury. However, AST values can be reliably used as a substitute to ALT if there's no ALT available in calculating the pattern of liver injury. GGT, however, is less reliable and should not be used as a substitute for alkaline phosphatase. And persistently elevated bilirubin and alkaline phosphatase in the second month of a drug-induced liver injury should be used as a marker that might predict the likelihood of a chronic drug-induced liver injury. Now, the most common causes of drug-induced liver injury worldwide are largely anti-infective medications, and this is predominantly antibiotics. This is seen as the most common cause of drug-induced liver injury in Spain, the United States, and Iceland, and the second most common in Latin America. As you can see, there are other agents, such as drugs used for anti-seizure medication or musculoskeletal drugs, non-steroidal anti-inflammatories and anti-androgens. Dietary and herbal supplements are becoming more common as causes of drug-induced liver injuries in the US, Iceland, and later on I'll show you the data from Australia. And what is becoming more apparent now is that the significant increase in anti-neoplastic drugs, and we'll talk about some examples of these in a little while, such as immune checkpoint inhibitors, but also other biologic agents that are used in the treatment of breast cancer. These are becoming more frequently seen as causes of drug-induced liver injury here in the US. There are two main forms of drug-induced liver injury, the first of which is intrinsic hepatotoxicity, and this is the classic expected drug-induced liver injury, which is direct, reproducible, predictable, and generally dose-dependent, and it can occur across a broad range of different species. For instance, if you give a human enough acetaminophen, you are going to cause hepatotoxicity. So that is a direct hepatotoxin, and it can be replicated in other animals as well. And then there is the idiosyncratic hepatotoxins. These are the unexpected. This is where you have used a drug countless times and you give it to an individual and they develop the 0.01 to 1% unpredictable increase in liver blood tests. These drugs themselves are not inherently hepatotoxic. There is the possibility that they form neoantigens with protein adducts that result in immune-mediated injury to the liver. These are not dose-related, can occur at small doses of medications, and they are not reproducible in other species. And there are two types. There's the non-immune, which lacks features of hypersensitivity, and the classic drug of indication here will be amiodarone. And then there's the immune-mediated hypersensitivity that can present in these individuals with rash, fever, joint pain, eosinophilia, Stevens-Johnson syndrome, and the classic example of this is amoxicillin and clavulanic acid. Now, there are variables that predispose individuals to developing idiosyncratic drug reaction, and this includes age, gender, pregnancy, which I'll talk about in a few minutes, malnutrition or obesity, and comorbidities including diabetes, underlying liver disease, and likely other host factors include the microbiome. Environmental factors include smoking, alcohol consumption, infection, and inflammatory episodes. And there may be drug-related factors as well, including the dose, the metabolic profile of the drug, the class effect or cross-sensitization with other drugs, and drug-drug interactions, particularly in people with polypharmacy. So I've spoken a lot about the issues here on the left-hand side of the slide, such as age and gender, malnutrition, but I also want to highlight this study that looked at drug-induced liver injury in pregnancy or immediately after pregnancy. In this case series, 44% of these drug-induced liver injuries occurred within the first trimester, 22% within the second trimester, and the other third of these drug-induced liver injuries in the peripartum period occurred within the first 60 days postpartum. Pregnancy-related drug-induced liver injury is associated with a higher initial and a higher peak AST when compared to drug-induced liver injuries in matched cohorts of patients that were not pregnant. And there is a higher prevalence of jaundice occurring in pregnancy. The fetal outcomes, there were 56% delivered healthy neonates, 19% that resulted in pregnancy loss, and 6% of infants had developmental delay. Maternal outcomes were quite good. So other forms of indirect drug-induced liver injury include drug-induced or autoimmune hepatitis or immune-mediated hepatitis in the case of immune checkpoint inhibitors. The classic drugs that result in autoimmune-like hepatitis or drug-induced autoimmune hepatitis are minocycline, nitrofurantoin, some of the anti-TNF agents, and high-potency HMG-CoA reductase inhibitors such as atorvastatin. Immune checkpoint inhibitors are well known to a lot of you because these can not only result in hepatitis, but also in colitis or other forms of injury. Now, there are ways to help us differentiate drug-induced autoimmune hepatitis from classic autoimmune hepatitis. We'll come to that in a minute, but the definite drugs that are associated with drug-induced autoimmune hepatitis include minocycline, nitrofurantoin, infliximab, alpha-methyl-dopa, adalimumab, and halothane. Probable drugs include propylthiouracil, isoniazid, diclofenac, etanercept, atorvastatin, rosuvastatin. And then possible drugs associated with an immune-mediated hepatitis, ipilimumab, nivolumab, pembrolizumab, indomethacin, and then there are some dietary and herbal supplements that have been associated with autoimmune or immune-mediated hepatitis, including black cohosh, germander, and hydroxycut. Now, the features that help us differentiate drug-induced autoimmune hepatitis from classic autoimmune hepatitis is that there is a hypersensitivity associated with drug-induced hepatitis in 1/3 of the cases where this is completely unusual and usually not seen at all in classic autoimmune hepatitis. There is a temporal relationship to starting a drug. in the drug-induced autoimmune hepatitis, not seen in classic autoimmune hepatitis. And there are common associations with HLA-DRB1 with autoimmune hepatitis and none seen at all with drug-induced autoimmune hepatitis. There can be concurrent autoimmune diseases in 14 to 44% of patients with classic autoimmune hepatitis, and these would typically be unusual or rare in drug-induced autoimmunity. Cirrhosis is a rare presentation of drug-induced autoimmunity, but can be present in up to 1/3 of patients with autoimmune hepatitis. So if you do that liver biopsy, which we will talk about later, you can see cirrhosis in 1/3 of patients. And if you do, it is highly unlikely that this has been a drug-induced autoimmune disease. Management of drug-induced autoimmune liver disease includes stopping the drug and administration of glucocorticoids, typically for a period of a few months to get the patient into remission, and then a rapid wean, after which the patient generally remains in remission. Relapse after corticosteroid withdrawal is rare, progression to cirrhosis is rare, and survival without liver transplant is excellent. Whereas in the classic autoimmune hepatitis, the treatment requires glucocorticoids and a prolonged period of immunosuppression with azathioprine. Relapse after drug withdrawal can occur in up to 2/3 of individuals, and progression to cirrhosis if the patient is not in remission can be up to 40%. Now, what about the immune checkpoint inhibitors? This is one such study that reports out on these patients from a multi-center cohort of 117 patients, all treated with immune checkpoint inhibitors. You can see the vast majority were treated with anti-PD-1 or PD-L1, whereas a subcategory of these patients were also treated with anti-CTLA-4 in combination or anti-CTLA-4 on its own. You can see that the classic pattern of liver injury is mixed in 1/3, cholestatic in 1/3, hepatocellular in 1/3. And there's a wide range of medications that are used on the right-hand side of this panel to treat these patients with immune checkpoint inhibitors. So as you can see, for those individuals who had a hepatocellular type injury, the vast majority of these patients receive steroids. Some of them receive steroids plus ursodeoxycholic acid. Very few of them receive ursodeoxycholic acid alone, if any. Some of them, about half of them, receive a second-line agent. For those individuals who present with a cholestatic type injury, steroids are still used, but most commonly in combination with ursodeoxycholic acid, or UDCA is used on its own. And we've all been told that we should not consider re-challenging these patients with the drug, particularly if they have grade 3 or grade 4 liver injury. But you can see that re-challenge has happened in this series in about 44% of individuals. That usually occurs because it is a necessary drug in the treatment of the patient's condition. But recurrence of liver injury occurred in approximately 1/4 of the individuals that did receive a re-challenge. Now, usually patients are re-challenged with a different agent when they are re-challenged. Now, the management of immune checkpoint inhibitor hepatitis depends on the grade of inflammation that is seen, and that is denoted by the level of ALT, AST, and bilirubin. And if it is a grade 1, you can continue with the immune checkpoint inhibitor with close monitoring and consider alternate etiologies for the elevation in liver blood tests. Monitor the labs at least once or twice per week, manage with supportive care, and determine the pattern of progression. If these individuals have grade 2, you hold the immune checkpoint inhibitor temporarily and see if there's recovery. And if it recovers to grade 1, that's okay. If not, you do consider using prednisone. For grade 2 hepatotoxicity with symptoms, you do administer corticosteroids. And if you have resolution of the immune checkpoint inhibitor hepatitis, you may resume the immune checkpoint inhibitor with close monitoring. For those individuals with grade 3 symptomatic liver dysfunction, fibrosis by biopsy, compensated cirrhosis, or reactivation of chronic hepatitis with ALT and ASTs in the 5 to 20 times the upper limits of normal, or bilirubin 3 to 10 times the upper limits of normal, you must discontinue the drug permanently, administer steroids as a bolus, and if the patient does not completely improve within several days, consider addition of mycophenolate or azathioprine. Laboratories should be monitored daily or every other day. This is typically a patient that would be in hospital, and you leave the steroids on for a period 4 to 6 weeks and then consider a taper. And for those individuals with grade 4, again, you permanently discontinue the immune checkpoint inhibitor. You administer steroids at a higher dose of 2 milligrams per kilogram per day. And if, again, they're refractory after 3 days, add in an additional agent. Now, in these situations, you do not retreat these individuals. There are other types of liver injury that occur. We should be mindful of the fact that some drugs are not necessarily inherently hepatotoxic, but because of effects that they have on the immune system or on some other viral application, they can lead to reactivation of other viruses. The classic example being rituximab, leading to reactivation of hepatitis B virus infection that results in liver injury. This, in its earnest sense, is a drug-induced liver injury. Similarly, drugs that lead to hepatic decompensation because of some mechanistic event that occurs, such as protease inhibitors in the treatment of hepatitis C, if the patient already has marginal liver function or decompensation, these drugs are to be avoided because they can lead to worsening liver failure. Drugs have been associated with development of neoplasms, particularly estrogens, resulting in hepatocellular adenomas. Drug-induced vascular liver injury can occur, and drug-induced portal sinusoidal vascular disease can also occur, and we'll talk about these in a few minutes. So I spoke earlier on about the fact that the increasing use of new agents to treat various different cancers is resulting in the development of drug-induced liver injury. This is a study that looks at the treatment of patients for breast cancer. And you can see here that these individuals are at risk of developing a condition called pseudocirrhosis. Essentially, it's a morphological change that is seen on imaging studies. Biopsies do not show nodular regeneration. We're surrounded by scar tissue, but they do show that there's evidence of an abnormal proliferation of hepatocytes. There may be sinusoidal dilatation. There may be perisinusoidal fibrosis. There may be nodular regenerative hyperplasia. These individuals are at risk of getting portal hypertension. And you can see that the most common agents that are associated with the development of pseudocirrhosis are alkylating agents, followed by antimitotics, antimetabolites, antibiotics, hormonal therapies, monoclonal antibodies. You can see here also that the number of drugs that a patient with breast cancer who has developed pseudocirrhosis has received, it's usually greater than 3 drugs in their treatment of their disease. 80% of the patients in this case series had breast cancer, and the median time from the development or diagnosis of pseudocirrhosis to death was on average 2 months. Some of this was liver-related death, some of it was progression of their cancer because one could not administer the therapies. I have seen 2 cases in the past 6 months of trastuzumab-induced sinusoidal obstruction syndrome leading to the development of pseudocirrhosis. In one case, the outcome was very good. We were able to stop the disease, completely resolve the portal hypertension, melted away. And the other case was picked up much later. The patient had progressive liver injury and progressive decompensation. Now, the diagnosis and causality assessment in drug-induced liver injury is quite difficult. It requires a detailed history, a compatible history with a temporal relationship to starting on a drug. This is easy if it is a one drug injury. However, most patients are on multiple agents, and sometimes it can be very difficult to know the start time and stop time of these individual agents. We should use judicious use of blood tests and rule out things such as hepatitis A, B, C. And when they're ruled out, we can consider ruling out hepatitis E. Hepatobiliary imaging is necessary, particularly for patients with a cholestatic pattern, and there is a place for liver biopsy. Now, the Drug-Induced Liver Injury Network assigns a causality assessment. They essentially describe it as being a definite drug-induced liver injury if it is beyond a reasonable doubt that the drug caused this. Therefore, you have ruled out all other causes. There's a strong temporal relationship. You take the patient off the drug, the injury gets better. Very likely is considered to be clear and convincing evidence. Probable is where the preponderance of evidence supports a drug-induced liver injury, and then possible and unlikely are where there's really no definitive evidence that this is a drug-induced liver injury. This is probably the best tool available to all of us in assessing patients for drug-induced liver injury. The NIH have come up with livertox.nih.gov, which is an incredibly useful resource because it provides not only the pattern of drug-induced liver injury, the testing that the patient requires, but also examples of cases that you can compare with the ones that you're seeing yourself in clinic. So the diagnostic approach to somebody who comes in with abnormal biochemistry, suspicious for a drug-induced liver injury, you should assess whether there's any skin involvement, kidney injury, previous drug-induced liver injury episodes, take a careful history of exposure to dietary and herbal supplements, medications, prescription medications, over-the-counter medications. Calculate the biochemical pattern of liver injury using the R score, which is denoted here in this calculation. And if the R score is greater than 5, that's hepatocellular, less than 2, cholestatic, between 2 and 5, the R score indicates a mixed drug-induced liver injury. We should search for alternative causes. So for hepatocellular injury, we should do testing for hepatitis A, B, C. In specific cases, when these tests return negative, we should check for hepatitis E, EBV, and CMV, particularly if there are symptoms of prodrome. We should look for the possibility of alcohol-related liver diseases, hepatic ischemia, or hypotensive episodes, and also check for autoantibodies and immunoglobulin G for autoimmune hepatitis. In cases of cholestatic liver injury, we should rule out benign and malignant biliary obstruction by imaging studies, testing for primary biliary cholangitis and MRCP for primary sclerosing cholangitis. In cases of mixed injury, we usually do combination of viral testing, autoimmune testing, history, as well as imaging. And then if all of these are negative, we would consider a liver biopsy if we have a negative or an incomplete response to D-challenge. We should also consider a liver biopsy if we're suspicious of the possibility of malignant infiltration of the liver or autoimmune hepatitis. Now, liver biopsy is not mandatory. However, it's strongly recommended if there's a possible autoimmune liver injury. D-challenge is the most important, and most cases show a steady decline in liver biochemistries after the causative agent is stopped. But persistence of elevated liver blood tests weakens the case of a drug-induced liver injury. Liver biopsy is indicated as well if there's less than 50% decline in the ALT within 30 to 60 days of removal of the drug. If there is an increasing ALT that is confirmed on a second lab test after removal of the drug, and if you have a less than 50% reduction in your alkaline phosphatase or bilirubin at 180 days. Other indications for liver biopsy include the possible need to continue medication for clinical reasons. So you may want to make sure that this is consistent with a drug-induced liver injury. Now, features on liver biopsy that are associated with bad prognosis include neutrophil infiltration, higher degree of necrosis, higher degree of fibrosis, cholangiolar cholestasis, adductular reaction, the obliteration of portal venules, and the presence of microvesicular steatosis. These generally portend a poor outcome. We don't normally use liver biopsy for prognostication, but if you get a liver biopsy and these features are seen on it, you should consider a higher level of care for these patients. High-Zimmerman's law also applies. In the late 1960s, Zimmerman discovered a combination of jaundice and drug-induced liver injuries to be associated with a 10 to 50% fatality rate from liver failure if the drug was continued. So the new Hy's law proposed by the Spanish Drug-Induced Liver Injury Registry is ALT or AST above the upper limits of normal, divided by alk-phos above the upper limits of normal. If that's greater than 5 and you have a bilirubin greater than 2 times the upper limits of normal, this indicates Hy's law applies and you should stop the drug. Now, the Drug-Induced Liver Injury Network has also proposed a severity index. They vary this from mild all the way through to fatal, which is pretty self-evident. Mild depends on the ALT and alkaline phosphatase. Bilirubin level is usually less than 2.5 and the INR less than 1.5. Moderate is where there's elevations in ALT or alkaline phosphatase, but again, the bilirubin level now is above 2.5 or the INR is above 1.5. And moderate to severe and severe include increases in ALT or alkaline phosphatase and the development of symptoms requiring hospitalization or signs of hepatic failure or other end organ damage. There are other slide rule prognostication scores that can be done that also predict outcome here, taking albumin, taking MELD score, Charlson Comorbidity Index, because these patients generally have other diseases, getting a total score along this slide rule allows you to determine the probability of a 6-month mortality. Now, dietary and herbal supplements are becoming more commonly seen as cases of drug-induced liver injury increase. They are seen in 40% of patients attending liver clinics. Alarmingly, most patients who use dietary and herbal supplements do not reveal this to us. And there tends to be a higher use of dietary and herbal supplements amongst Asians, amongst younger people, amongst highly educated people, and those that are more health conscious. They are typically used for weight gain or weight loss, bodybuilding, menopause symptoms, gastrointestinal disorders, liver diseases, and neurological complaints. In Australia, we've seen a significant increase in dietary and herbal supplements resulting in liver injury from 15% between 2009 to 2011, up to 47% between 2018 and 2020. And these drugs, unfortunately, are poorly studied. They are manufactured in various different places without a whole lot of good quality control. The indication is never for a disease. It is always for management of symptoms. They are marketed on preclinical evidence or promoted based on ancient classical texts or generational knowledge. And one of the interesting things is that one of our colleagues in Philadelphia performed a study where they took dietary and herbal supplements that required patients to be admitted to the hospital. They took blood from these individuals. They sampled the medication itself. In 50% of the cases, they found products in the patient's blood that was not on the list of ingredients. In an additional 50% of cases, they found products within the patient's blood. They found no evidence of ingredients in the product that was labeled on the label of the product. Now, de-challenge should be done in all cases. It should result in improvement after cessation of the drug. Sometimes the injury can take a few days to several weeks. I saw a patient this morning who had fluconazole-induced hepatotoxicity. She's been off the drug since mid-March. Her alkaline phosphatase still remains elevated at 150. The speed of improvement is variable. It's possibly slower in cholestatic liver injuries, and improvement is not always reliable. It sometimes may be just coincidence. Re-challenge is currently the strongest evidence of proof of causality, but we do not recommend this at all. Deliberate re-exposure to a non-essential drug suspected of causing drug-induced liver injury is strongly discouraged and can hardly be justified. Liver injury caused by unintentional re-challenge does sometimes occur, and in situations it can confer a high risk of mortality. This is a study where re-challenge did occur in idiosyncratic drug reaction. As you can see here, in 71% of the cases, 41 patients, it was an incidental re-exposure. When the incidental re-exposure did occur, it was sometimes due to the fact that the history of DILI was not communicated in the medical record, and therefore, when the person re-prescribed the medication, they were unaware of the previous first episode of drug-induced liver injury. And sometimes it occurs because of lack of diagnosis of the first episode of hepatotoxicity. 14% of re-challenge was due to the fact that the drug was irreplaceable. 6% was because the patient went back on it, ignoring medical advice. And in a small number of cases, 5% or so, there was no known reason. The first episode is usually associated with mild or moderate, but as you can see, after positive re-challenge, there are cases of severe injury and fatal injury that can occur in re-challenge in the setting of idiosyncratic drug reaction. Now, chronic drug-induced liver injury is the persistent abnormalities of LFTs 3 months after a hepatitic injury and 6 months after a cholestatic or mixed drug-induced liver injury. Some institutions suggest that we should think about chronic drug-induced liver injury after 12 months. There are rare instances where drug-induced liver injury, particularly cholestatic drug-induced liver injuries, can result in cirrhosis. The vast majority of people, however, 92% of them, resolve their abnormal liver blood tests less than 1 year after drug-induced liver injury. The treatment of drug-induced liver injury is to discontinue the implicating agent. In patients, particularly with ALTs, AST greater than 8 times the upper limits of normal, 5 times upper limits of normal for more than 2 weeks, 3 times upper limits of normal if there's increase in bilirubin or INR, and 3 times upper limits of normal if there are symptoms. There are some specific therapies. N-acetylcysteine should be used for acetaminophen toxicity. Cholestyramine should be used for leflunomide toxicity. Carnitine should be used for valproate toxicity. Non-specific therapies often used, rarely proven, ursodeoxycholic acid, corticosteroids. And then there are considerations for corticosteroids or GCSF in patients with acute liver failure, and of course, liver transplantation. So in conclusion, drug-induced liver injury is common. It is difficult to diagnose and requires a high degree of suspicion and a lot of work. Tools for diagnosis and predicting outcome are not very good, and there's a need for a more sensitive or specific biomarker in the diagnosis as well as in the prognostication. Dietary and herbal supplements are increasingly associated with drug-induced liver injury and sometimes can be more severe. The outcomes are worse when compared with prescription drug-induced liver injuries. Chronic drug-induced liver injury is rare, but is a real outcome, and all patients should be followed until complete resolution of their abnormal liver blood tests. Thank you very much for your attention. Take care.